Hi, I'm Shannon McPhee. I'm an associate professor in the Department of Emergency Medicine at Dalhousie University, and we're going to talk about the most up-to-date management of gastroenteritis in children. To start off with, we have a few pre-test questions. The first one is, dehydration is easy to assess, and you can safely assess children for a degree of dehydration using Gestalt. True or false? The second question, each of the elements will assist us in determining the degree of dehydration in children over 6 months except A, general appearance, B, eyes, C, skin turgor, D, mucous membranes, and E, tears. Gastroenteritis is extremely common, and this is one of those things, if you're working in an emergency department, there's no need to reinvent the wheel every single time that a child comes in with vomiting and diarrhea. And there's a fair amount that you can do as an emerge team to help prepare for these children so that while you're caring for other children, treatment can be going on in the background. And so the three big messages here, by the end, you're going to know how to do a hydration assessment in kids. Second thing is you'll have a good approach to rehydration therapy for your department. And the third is that you'll be able to understand the role of antiemetics in gastroenteritis. This is a care pathway that's used in Nova Scotia, also at the IWK, and it's based on a TREC-based protocol, so translating emergency knowledge for kids. And the reason that we have a care pathway is some of the assessment is done right from our triage nurses, and they're able to start hydration therapy as well as antiemetics based on what they find. And so whenever you have a pathway, it's important to choose the right people to put in that pathway. And children less than 6 months would be excluded from this. They are much more difficult to assess, and the differential for those children who are vomiting may be quite different than the older child. This care pathway only includes those who are non-toxic and have a limited history of vomiting and diarrhea, so less than 7 days for vomiting and diarrhea. And we also expect if you've done a blood glucose that is normal, so between 3 and 13, if you've done that along the way. Anyone who looks outside of that, so who has a chronic medical condition, has localized abdominal pain that's anywhere but around the umbilicus, really should not be put into this pathway. So the first assessment that we're going to do is we're going to use a validated clinical dehydration scale, and we've chosen this one because it's been validated in the literature, and it's also easy to use. These are things that we would look at all the time, and there are 4 components that you're going to look at. So 1, general appearance of the kid. 2, we're going to look at their eyes. 3, assess their mucous membranes. And 4, look for the presence of tears. So just kind of moving back to the top, you get either 0, 1, or 2 points on each of those categories. You get 0 points if you're a normal appearance. You would get 1 point if the child is acting thirsty or restless. If the child is lethargic, so that means sleeping and extremely difficult to wake up at a time that the kid should be awake, and irritable, so inconsolable when touched. And a child would get 2 points on this scoring system. They were drowsy, comatose, or would limp. From an eye perspective, 0 points for normal, 1 for slightly sunken, and 2 for very sunken. And we'll show some pictures of that in the next couple of pages. And mucous membranes will be assessed as either moist, sticky, or dry. Tears, sometimes you're going to see those on the exam. Sometimes you may have to rely on the history that the parents are giving you. So these are a couple of pictures here from the internet. The picture on the left would receive 1 point. So those eyes are slightly sunken. You can see that they're a little bit dark below her eyes. And the child in the picture on the right has severely sunken eyes and would receive 2 points on that scale. Moving back to the mucous membranes, the bright-looking baby on the left has moist mucous membranes. Up close, you could see a pool of saliva under the tongue. The tongue is glistening. And it's actually fairly difficult to find a picture of dry mucous membranes on the internet, but this large cat here suffices, and you can see that that tongue is completely coated and the entire mouth is dry. And so that would receive a 2 point on that particular scale. So what do we do with all this information? We know that most kids who come to emerge departments in Canada will receive a clinical dehydration score of 0 to 1. So that means that they're either not dehydrated or minimally dehydrated. And from the work done in Alberta, we know that about 90% of kids visiting emerge departments will fit in that category. Those guys, you don't need to do anything different. So in the past, we may have tried to offer these kids Pedialyte or other kinds of solutions, but we know that it doesn't really matter. If you're not or minimally dehydrated, they can be offered what they'd like. For the children who have a clinical dehydration score of between 2 and 4, they're moderately dehydrated, and the first step for those kids is to try oral rehydration. Oral is always best. It's less invasive, less pain for the kid. It's replicable at home, and so the first step is really to sort of give that a go. And children who are severely dehydrated and have a score of 5 to 8 should be placed immediately in a patient care room, and they're going to require individualized care. Many of those patients at that end of the spectrum are going to need basic blood work, and they are probably going to need IV hydration to help move things along. So this talks a little bit about oral rehydration therapy, and one of the things that we know, so aside from it being less invasive and less pain, the hospital length of stay in your emerge is actually the same whether you go for IV or oral, and there's no significant difference in treatment failure. The big question is how much, and if you're going to challenge these kids, it's got to be worthwhile. It's got to be able to turn them around. And I always remember it's as easy as 1, 2, 3, and that's ounces. So if you're between 6 months and 5 years, you need to take in 1 ounce or 30 mils every 10 minutes. If you're between 5 and 10 years, you need to take 2 ounces, so 60 mils every 10 minutes. And if you're bigger than 10, you should be taking in 3 ounces or 90 mils every 10 minutes. And those are targets that you should set with families. And it's often useful if they've got a smartphone in there for them to actually set their timer to 10 minutes so they can remember what to take. And we often give them pieces of scrap paper and a pencil just so that they can copy that down. And that's something that we expect them to keep track of at home. And so it's good training when you have that patient in front of you in the emerge to start that. One of the things that has revolutionized care for kids with gastro in North America over the last couple of years is work that Stephen Friedman published in the JAMA in 2016. And up until that point, the dogma was that you needed to use an oral electrolyte solution to rehydrate kids. And this was a really well done randomized trial that put to head half strength apple juice, so half water, half apple juice, versus an oral electrolyte solution that was flavored as apple. And they were able to enroll kids who were between 6 and 60 months, and they enrolled almost 650 kids. And they looked at what happened with these kids, and there was absolutely no difference in these two groups in terms of the need to start IV therapy, no difference in the number of kids who were hospitalized, who had an unscheduled medical visit in that next 7 days, and no difference in sort of crossover. And so this really changed things for us, and it's given us an opportunity to offer kids something other than Pedialyte in our emerge. And I would say that many emerge departments across Canada have gone to using half-strength apple juice in children that are bigger than 6 months, and I've had excellent experience with that, and it's certainly something that we're doing at our center. So some of these kids in that moderately dehydrated group, you're going to try them with oral rehydration therapy and they're going to fail. And if that happens, your next step is the use of ondansetron, and that comes in an orally dissolving tablet. And if you get to that point, ondansetron has been well studied, again by Stephen Friedman, and that reduces vomiting in the emerge. It reduces the need for IV hydration and also the need for admission. And so that's also something that's really changed care of these children with gastroenteritis over the last decade, as it were. And so In terms of the reduction in IV rehydration, the number needed to treat is only 5, and for hospitalization, the number needed to treat is 17. One of the interesting things is that there's no difference in return visits in those kids who have received ondansetron or not. And the only thing that we do in terms of chatting with families about it is that there is a slight increase in frequency of diarrhea after you've had ondansetron. So something that we talk a little bit about, doesn't tend to be very clinically significant for people. Is it safe? One of the main side effects of ondansetron is that it prolongs the QT interval. You need to be really careful in assessing patients who are already on medications, and there's an extremely long list of medications that prolongs the QT interval. And so if your kid's on a med, you need to go to that website and ensure that there's no incompatibility between these two things. Once you've cleared that off, it's important to understand that Health Canada does have a warning on this particular drug, and we know that there are 11 pediatric case reports of arrhythmias with its use. And there were 2 interesting fatal cases. One was a 10-year-old who came into the emergency department and received 4 milligrams intravenously of ondansetron twice, and that child died. And another one was a 3-month-old child who received an oral dose of ondansetron and was found on autopsy to have an undiagnosed congenital cardiomyopathy. And what you'll notice about these 2 cases are that one was a very young baby, and so it is not recommended in children who are under 6 months because the rate of undetected congenital abnormalities is higher in that age group. And the second piece of things is that in the setting of acute gastroenteritis, the risks of IV administration are not worth it, and the risks of multiple doses are not worth it. And so, taking direction from the Canadian Pediatric Society, oral ondansetron therapy as a single dose should be considered for infants and children 6 months to 12 years of age who present to the emergency department with vomiting related to suspected acute gastroenteritis and who have mild to moderate dehydration or who have failed oral rehydration therapy. And so the things that are really important to remember about this is that this medication is likely to help your child. It's likely to reduce vomiting and the need for IV starts, but you need to be very selective about who you're trying it in. You're going to avoid it in children who are under 6 months, and you're going to avoid IV use. And you're going to stop giving multi-dose ondansetron. And so there are several case reports that have popped up with the use of ondansetron, particularly that given as a home medication. If children are having ongoing symptoms at home, the best bet for them is to come back to the hospital and to be reassessed. They should not be given multiple doses of ondansetron at home. So just looking back to this diagram here, we've talked a little bit about the management of children who have low dehydration scores between 0 and 1 being managed with an age-appropriate diet. Those who are moderately dehydrated are going to be trialed orally, and if that fails, they're given ondansetron. And then there are the patients that are going to come in, and it will be rare, that are severely dehydrated, so have a clinical dehydration score of between 5 and 8. In that particular circumstance, basic blood work, including electrolytes, gas, blood glucose, BUN, and creatinine should be done. And these kids need a 20 cc per kilo normal saline bolus. They may need up to 3 of those boluses to restore their hydration. And we often end up running them at D5.9 normal saline at 1.5 times their maintenance rate for a few hours, or even on the inpatient unit after they've presented in that way. So back to the testing. Dehydration is easy to assess, and you can safely assess children for degree of dehydration using Gestalt. And the answer to that is false. You're best off using a validated score such as the clinical dehydration scale. The second question is that skin turgor is not used to evaluate dehydration in children. This is not a reliable skin finding, often not sort of reproducible, and so none of the major scales have included skin turgor as part of the assessment. So in conclusion, dehydration assessment does require a scale. I always remember it as 1, 2, 3 ounces every 10 minutes orally, depending on your age. Oral ondansetron, so one dose for kids who are more than 6 months who have failed oral rehydration therapy. And in your institution, it's very acceptable to use half-strength apple juice as an alternative to oral rehydration solution in a healthy population. So this particular study was done in Canada, where children are robust and have very few underlying conditions. I would not recommend this particular study to be used in a country where kids may not have clean access to water or may have health conditions or underlying health sort of circumstances that are different from here.